Hopefully, everybody else will join us soon. So, welcome. I cannot believe it is week 5 already. It's crazy. This term is going by super, super quick. But we have a lot of stuff to cover today. Um, I will share my screen. You guys can see the PowerPoints. Let me just make sure we can. All right.
Are
Um,
we are we continuing where we left off?
Oh, you know what? Thank you so much. I just realized that when I pulled up the PowerPoint. Thank you, Joseph. Oh, let me get that one up real quick. Everybody's coming
Miss Martinez, did you do roll call, I guess?
in. I have not. Change
Okay.
your name though, Marcy. Add your last name.
Yes, ma'am.
All right.
Sorry, I'm like 2 minutes late. My computer was loading really, really slow.
Oh, I'm sorry. I thank you. I appreciate you apologizing. All right.
Miss
So,
Martinez,
yes. Yes.
I'm gonna mute my mic because I'm in school and there's a few of us here, and Ashley is trying to get on now.
Okay.
Sorry. My computer is like loading really slow. I don't know if it's like going through an update or something, but I here, let me show you. Hey, pan the camera this way. Oh, it just got like this. It was black for about 5 minutes.
I'm gonna mute it though.
Oh no.
I'll unmute when I'm talking.
Okay, no worries. All right, so I believe we left off on the nursing process for pain. Is that correct?
I
Yes, ma'am.
believe so.
Awesome. All right, just wanted to make sure we were all together. Let's see. All right, try this again. Oh, my chair is stuck. All right, don't mind me. My chair is stuck as I roll all over the place. Okay. All right. Start the class off being funny. All right, so I'll share my screen again so we can finish these last couple slides. So then pain, and we know pain is right our fifth vital sign. It is subjective, right? It's what the patient tells us it is. Um, so again, with the nursing process for pain, remember, pain is not a normal part of aging, right? We don't just develop pain because we're getting older, although sometimes it feels like that. Again, it's subjective. We always ask them to about their pain. That will encourage them to report it more quickly. Um, and a lot of times in our confused adults and this is a really hard part of working in geriatrics is with our confused adults. Dementia, Alzheimer's, those things, assessing pain can be really difficult. And we do have different assessment tools that we can use for those that maybe can't verbalize their pain. We use more behavioral type of assessment when we're looking at pain and those that really can't tell us. But it can be really difficult to assess pain. Um, so it's always something to be aware of. You don't always, you know, um, they're not always, I'm in pain. They may express themselves in other ways. So when we look at the pain assessment screening tools, we have the PQRST. Everybody's popping in now. So we have the palliative or the parogative, and this is what makes the pain better or worse. And we try to use a combination of what we call pharmacological as well as non-pharmacological techniques to treat pain. So sometimes turning and repositioning, distraction, dimming the lights, making the environment a little bit, more settled. Um, and then, we always have medications, right, that we can help to treat pain. Quality is how is the pain described? And so when we look at quality of pain, give me some examples of quality of pain, like words.
Sharp.
Okay. All right. So,
Stabby.
right, there you go. Yep. You're burning, you're stabbing, shooting pain, dull,
Sharp.
yep, right? All of those things, right? So that is your quality. Radiation, does it travel? Does it spread somewhere else? And if it does, where does it spread to? So, sometimes like, neck pain, right, goes down into your shoulder, or, like sciatica, right, goes down the back of their leg. The severity, that's your pain scale. On a scale of 0 to 10, with 0 being no pain, 10 being the worst pain, right? Where does that pain fall? And then temporal means, is this constant pain or is it something that comes and goes, right? And a lot of that too is like one, is there something that aggravates it even more? Um, so that's the PQRST. That's one of the screening tools that you can use, and you'll get as much information about that patient's pain as possible so that we can, document it and get the appropriate interventions put into place. This is what I use a lot. This is your PAN-AID scale, and this is what I was saying, especially for your dementia patients, or even in some of your nonverbal patients that may not be able to say, "Hey, I'm in pain, like help me." And so we scale it. And so breathing, independent of vocalization, right? If they, have normal breathing, obviously it's a 0, but labored breathing or noisy labored breathing, Chain Stokes, negative vocalizations. Again, this isn't going to be I'm in pain, right? This could be um, occasional moaning or groaning, or, up to repeated calling out and crying. Facial expressions, are they smiling or inexpressive, sad, frightened, frown, facial grimacing, the body language, consolability. So you'll basically add up the scores. So obviously, if we had all of these, right, that would be 2, 4, 6, 8, 10, right? So that's, a pretty high pain score, right? So any score of 4 or greater should be reported for pain intervention to be implemented. And like I said, I use this all the time. For some reason, I don't, and it's interesting. I don't right now. I don't have a whole lot of dementia patients, but I do have a lot of nonverbal patients. Because of strokes and things like that. So I've been using this scale a lot more than using the traditional, 0 to 10. And it can be very effective, but you have to be able to recognize some of the cues that your patients are experiencing. Come on. There we go. All right, so here we have a case study. All right. So Rose lives in a secured unit for patients with dementia. She has episodes of anxiety and confusion and is sometimes aggressive with staff and roommates. Which of these interventions would be helpful when working with Rose? So let's see. So again, she lives in a secured unit for patients with dementia. She has episodes of anxiety and confusion, sometimes aggressive with staff and roommates. So what do you think are some good interventions that we can use for Rose? Force her to reorient to reality when she gets confused, change her room whenever she gets upset with a roommate, assign new caregivers when she gets upset with a staff member, use familiar objects or family photos to encourage her to reminisce when she starts to get anxious, provide a structured, stable environment, or use physical and chemical restraints. So what do you think are going to be some good interventions to work with this community or with this patient, sorry?
What
Use
about DV?
familiar objects to
Uh-huh.
reminisce.
Mm-hmm.
Assign new caregivers.
Provide a structured, stable environment.
Provide a structured, stable environment. Awesome. Good job. So yes. Um,
That's it.
we can't force her to reorient, right? If she's got dementia and confusion, right? Orientation is not going to help her, right? We have to meet her where she is. Changing her room, especially with confused patients, right? That can actually sometimes make them more aggressive and more confused, right? Because you're constantly changing their environment. Assigning new caregivers when she gets upset. So one of the things that we do try to do, especially with confused patients, is have as much consistency with staff as possible. So yes, we want to use familiar objects, family photos, encourage her to reminisce, provide that structured, stable environment. And then we obviously don't want to use any kind of physical or chemical restraints. Those can be very dangerous when we look at that elderly population. All right, so here we have another. Mary moved into a nursing home 2 weeks ago. She believes the staff are stealing her belongings. She can't understand why people come in and out of her room all the time, taking her clothes, removing unfinished food she was saving for later. She has started hoarding food and hiding her things. How would you handle Mary's suspicious and hoarding behaviors? Right? So, right, we have someone that, moved into a long-term care setting, right? She obviously is probably a little bit confused and doesn't understand where things are going, right? So what do you think are some things that we can do for Mary?
Redirect her.
Oops. Okay, redirection.
Reassure her that if somebody is taking clothes out of her room, they're probably just taking them to be washed and they'll be back soon.
Mm-hmm. What about hoarding? Mm,
That one I feel like is a tough one because sometimes you can redirect them and reassure them that like more food will be provided to them. Um, and other times they're still even protective over that if you try to remove it.
yeah. So, there's a lot of things that, right? Let's see what there's a lot of things here, right? It's a new environment. What are we gonna do here? So let's go. So again, moving into a new environment. Just like we were talking about,
Will
like,
we talk
you
to
know,
a family member too to see what her likes and dislikes is, being that she's moving into a new environment? See,
absolutely.
see if she was hoarding food at home and maybe she had a special place she liked to put her food, and maybe we can accommodate her and put it in her room with some familiarity and something similar to that effect.
Yeah, I mean, they're allowed to have snacks, right? So trying to make it as comfortable for her as possible, that home-like atmosphere. Dementia, you can't reason, right? You can't really redirect, right? We have to meet them where they are. And
Mhm.
so make it as, simple as possible. There's always going to be, especially in the beginning, there's going to be a lot of mistrust. And so that is where building that therapeutic relationship with your patients as much as possible, even with your dementia clients, is going to be helpful. So I'm just going to use this one. I have an example of this. So we had a client or a patient who she had Alzheimer's. She had fallen and broke her hip, and that's how she ended up. For some reason, I don't know if I reminded her of like a family member or anything, but even when she was agitated and upset, she would hit my CNAs and she would hit other nurses. But for some reason, she really liked me. So I was always able to go in and calm her down. And then even when she transitioned over to long-term care, she refused to take her medicine. So I would have to go over and give her medicine because I was the only one that was, that she would take her medicine from. Um, for whatever reason. I don't know what the reason is. And I think I probably reminded her of her daughter or something along those lines. But it's trying to just make it as simple as a process as possible, helping them to adjust. A lot of times though, they will start to settle in. Sometimes they don't, sometimes they do. Um, but, kind of just like I said, meeting them where they are is going to be really important when you're working with dementia patients, because they really don't understand. They don't know really what's going on. They just know it's new, it's different, right? And it can be unsettling for them. All right, now we have Joe. And Joe lives in an assisted living facility for older adults with dementia. He enjoys watching news and sports on TV, reading the newspaper. Lately, he started wandering out of the apartment. He gets irritable and sometimes aggressive when staff ask him not to leave alone. What do you do to help Joe maintain as much independence as possible while keeping him safe? This is a good one.
Make them do some activities or, stuff like that, like activities with the other patients.
Okay, so do some activities, right? Try to keep him busy, right? So he doesn't have the time to wander. Okay. Um, excuse me, because we got to be careful, right? Because he's wandering out of the apartment. What happens if he gets out of the area, right? He is a potential could get hurt and injured. We and medication, and pharmacology, the we really try not to use medications for wandering only because a lot of the medications that we use for sometimes um
Make them drowsy.
it will make them drowsy, but it also increases their risk for injury. And some of them have even caused death in the elderly population, especially some of those antipsychotics. Making sure that the we limit as much of the fall risks as we can. Activities, somebody said activities, that's a great way to do it. Visual signs are awesome. I know this sounds really weird, but we used to put stop signs on the door.
Yeah.
Okay. Stop signs is something visual. Most people know, you know what a stop sign is. So that may help to redirect them as well. Um, Velcro net gates. Those are, that's what we had. So it's a Velcro net gate that kind of hung on the doorway and it had a big stop sign on it. And so they know for some reason, though they just knew not to go past there. And then just the redirection, what you said with activities, getting them, keeping them busy. Um, it's just very common for them to wander. And so just making sure that we're providing for their safety. And that's always going to be the big thing is providing for their safety. That's our biggest concern when we're working with, some of these dementia and Alzheimer's patients. So, all right, that caught us up. Thank you for the reminder. So then this week, I don't know why I stopped sharing. For this week, we're going to talk about chapter 11. So self-perception, and self-concepts. So I'm trying to get to the right side and it's not working here. So it's going to be 11, 12, 13, and 16 in your basic geriatric book or basic geriatric nursing text. And then in your concepts books, it's chapters 3 and 21. So chapter 11 is self-perception and self-concept. Chapter 12 is roles and relationships. Chapter 13 is coping and stress. And then chapter 16 is sexuality and aging. So all kind of the chapters are going to be in this PowerPoint. So family dynamics, and sexuality, family dynamics, right? The interrelationship between people, in or individual family members, whether it's positive or negative. family dynamics change who we are, how we view the world outside of our family, right? You can kind of look at your families and see how you guys interact, right? And how that has caused your view of the world to change, or, how it is, I should say. Sexuality, according to the World Health Organization, is a central aspect of being human throughout life, which can encompass sex, gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. All right. So, chapter 11 is self perception and self concept. So, and you can even look at yourselves and things that thought as you were younger, as you're getting older. Your self-perception, your self-image changes as we get older, right? It doesn't matter if you're 20 or 60, right? As we grow, right, things change. Successful aging is perception and attitude, right? Not years or health. Um, so and I'll just use, like, I remember when I was younger, right? I was like, oh, my grandmother is so old. And I'm like, look back at pictures. My grandmother wasn't old. She's the same age as I am now, right? And so I don't consider myself old, right? So your perception does change. And like I said, it's not years or health, it is perception, right? Attitude we know is everything. Um, Older adults gain self-esteem from strong personal values, a sense of control of their lives, and our self-concept. That's our beliefs are about ourselves, our values, our abilities, our characteristics, our roles, right? And just, not everybody is going to get dementia. Not everybody is going to have pain. Not everybody's lives are the same, right? And so, how you see yourself, and our self-concepts definitely have an effect on how we live our lives. So, threats to self-esteem and self-concept. So, any loss in their ability to care for themselves can alter your self-esteem and your self-concept. And the more frequent the losses and the significant losses threaten our perception of control and lead to a sense of powerlessness. And so I'm going to give you an example again. So back when I first started nursing, patients that had, hip replacements, they would be literally non-weight bearing in bed for 6 weeks. Okay. Things have changed so much over the course of, the 25 plus years I've been a nurse. Um, and well, a lot of times what we would see these very active elderly people come in that were walking, that were working, that were very active in their lives, and something devastating like a fall causing a hip fracture occurred. And now we're telling you that you have to stay in bed for 6 weeks. What do you think happened to them?
Confidence is shot.
Confidence is shot.
Getting
Fear of
depressed.
They become
Frustration.
depressed. I'm sorry, Aiden. Who said, I'm sorry.
Frustration.
Frustration. Okay. Fear, right? Fear is a big thing. You fall once, right? Especially as we get older, right? The fear of falling again. And because now we've confined them, right? They can't get up and move around like they used to. I saw many just continue to decline and then eventually pass away. Because of that. And I'm talking about patients that were very active prior to their fractures. We've made a lot of changes now, right? Our hip fractures or our hip surgeries, they don't stay in bed for 6 weeks, right? They're up, moving, they're walking, right? For one, we have better technology, right? Better ways to perform these surgeries. And two, what have we realized over time, right? The more you lay around, the worse it gets. And so we've had much better outcomes. And I'm not saying everybody has had great outcomes, but there has been a significant change. It's the same thing with knee replacements. You have a knee replacement, we'd put you in bed. You would be on a CPM machine, which is a continuous passive motion machine to move the knee, but they would be non-weight bearing, and we would also see those issues with them. So imagine, being active and having a stroke and then not being able to get up and take care of yourself. Um, so it can be very devastating to them. Also, loss of emotional support system. So losing a partner, friends, family, also changes the sense of who we are, right? Like, my husband and I have been married for 30 years. Wow. Been together longer, but we've been married for 30 years. Like, if I didn't have him, I'm not sure what I would do. Right. Like, so, it does change a lot. And placing them in nursing homes can lead to feelings of rejection as well as that altered self-concept. And so, we have to see how we can, help them adjust. Just think like most of your long-term care facilities, they're just two to a room, right? So you may have, you had your house, right? You had all your stuff, you had room to walk around, you had privacy, right? And now you go into a long-term care facility and you have to share a room. There's only so much room in there for your belongings, right? You can't bring everything with you. So that's a loss too, right? Not only did you lose your independence, but now you're losing all your belongings, and that's a huge adjustment. Oops. Sorry. Oops. All right, so Mrs. Jackson is 82 years old. Her husband died 2 years ago, and she had a mastectomy after breast cancer. She tells the nurse, I don't recognize myself anymore. I used to be a happily married woman. I was attractive and had a comfortable house and good friends. Now I feel like I've lost control. I look in the mirror and I don't recognize myself. So, what changes have led to her altered self-concept and her altered body image? What changes do you see? What changes have occurred?
Losing her home,
Losing her home,
her
Vasectomy.
husband.
right? She's lost, she had her mastectomy, right? So she's had some significant changes. So what do you think are some things that we can do to help build her self-esteem and her self-control,
You could remind her and tell her that she's beautiful.
right? The self-affirmation, yeah.
Mhm.
Probably take her to the salon and get her hair done, nails done, stuff like that.
Get her hair done, get her nails done, right? What are
Help
some, go
help her
ahead.
reach out to her friends as well. And maybe like have her encourage her friends to come visit her.
Absolutely, right? Reach out to her
Um,
friend. And, just because she's in that facility doesn't mean she can't go out to lunch,
Yeah.
right? Or talk
like
with her friends.
reminding her that just because someone is aging and just because things are happening doesn't mean that you lose yourself. Doesn't matter what things happen.
Right, absolutely. And like I said, it's hard, right? You were married, you had a house, you had good friends, and now you're here. What about activities, right? A lot of, different types of activities. We have some that go out to the churches and do volunteer work, right? So
Community
there's
service.
things that they can do. And even what is it? They have like resident council, right? And so just kind of like a student council, they have resident council, they can address things, they can plan parties, there's lots of things that they can do. So really trying to get her involved in that cohesive group. And remember, not everybody in a long-term care facility or a nursing home has dementia, right? So there's going to be other people like her that are alert and oriented and aware, right? So that they can, she can still interact. So encouraging that socialization is great. So with that, some of the signs and symptoms of depression. And separation is such a huge part, but changes in mood, energy, restless, lack of concentration, um, difficulty carrying out ADLs, like I was telling you, like the active ones, right? Now they're in bed for 6 weeks, they can't move around. They start to decline. So we really have to be careful. Eating, sleeping too much or too little. And this is a big one. And this is why activities and socialization is so important because you don't want them laying in bed all day, right? You want to get them up just like you would if you were living at home. You get up, you shower or whatever, get dressed, right? Get out of your room, go to the dining room for breakfast, right? Encouraging that socialization. Increased worry, excessive use of alcohol or drugs. So yes, we know that the elderly and the older adults drink, right? They also can use illicit drugs. Sadness, hopelessness, avoiding eye contact, crying, or even suicidal ideation. And one of the big things that we look at with depression and the suicidal ideation is giving away their belongings. Um, Older adults, we know that there's a huge population of older adults, right? They account for 18% of all suicides. 18%. That's a big number. It doesn't seem
Hmm.
like it, but when you look at it, 18% of all suicides is in our aging or in our older adult population, right? I told you about the lady at the hospital, right? Did I tell you? Maybe I told another group. Um, This was, gosh, maybe last year, the year before. I don't remember. Um, but her husband was in a rehab facility or a rehab hospital, it was an acute rehab hospital, and she came in. I don't know, of course, I don't know what was wrong with him. She went to the hospital, she shot him, and then committed suicide. So it was a murder suicide in the hospital that this occurred. So when we got to look at this can happen, not just in younger people, this can happen in our older adult population as well. So being, trying to really, pay attention to those subtle signs, right? Giving away their belongings, the nobody will miss me when I die type of conversations that we have. Um, all of these things in decreased interest in their activities, unexpected weight loss, right? These are all things of depression and possible, thoughts of suicide.
Sometimes their families are so encased in their own life that they don't even see it.
Mm-hmm. Mm-hmm. Yeah, it's very true. That is very true. All right. So a nurse is bringing an 80-year-old man to the exam room at a veterans clinic. He has not come in for a physical exam since his wife died 2 years ago. When asked why he came in today, the patient says, well, I came here because I don't sleep well at night and I am just not hungry anymore. I'm just tired of it all. I have nothing to live for anymore since my wife died and my son moved out of state. I've given my favorite toy soldier collection to my grandson, and he didn't even call to thank me. What's the use? What concerns do we have for our little 80-year-old veteran?
Suicide.
Depressed.
Okay, we're
Depression.
concerned about suicide. Why? What are some of those key?
What's the use?
What's the use?
I have nothing
I
to
have
live
nothing to
for.
live for anymore.
Yep. And
Giving away things.
giving away things. Very good. Oops. And so again, likely experiencing depression, maybe contemplating suicide. So we want to ask directly, are you feeling like hurting yourself? And I know that sounds like a very blunt question, but that is how we have to ask it, right? Um, what other essential information should we obtain if we think that somebody uh, has, is thinking about killing themselves or committing suicide?
If they
Mhm.
have a plan and if they have access to weapons.
Do they have a plan? Do they have access to weapons? So, do they have a means to carry out their plan, right? Um,
So
so
would you
again,
watch them when it comes down to their medications?
we can look at their medications, absolutely. Absolutely, right? What medications, are would be potentially more dangerous for them.
Hmm.
So older adults, like I said, 18% of all suicides. All right. They also have a higher suicide or a higher rate of suicide completion than do the other age groups. And they also tend to use more violent methods to end their lives. So firearms, overdoses, suffocation are some of the common methods that we will see with the older adult. They're also less likely to verbalize their intentions, right? They'll still make those statements like we see, but, and like somebody else was saying, was it Maisha, was it you that said a lot of times the family are so involved in all their activities, right? They don't see what's
Yes.
going on. So, yes, we want to know, do they have a plan? If a weapon is available, be very careful, listen very attentively. Anxiety. Anxiety, I'm sure everybody's had some sort of anxiety at some point in their lives. That's that uneasy feeling. Um, and it could be a vague threat, it could be an unidentified threat, right? What makes one person anxious that may not, may not make somebody else anxious, right? Everybody's feelings about that. And it can be acute or mild, moderate or severe, or it could be acute, as in something, you know, um, all of a sudden happened, right? That increased my anxiety, or it could be something that is chronic. And so I will tell you that a lot of times in a lot of my dementia patients, unfortunately, they have some level of chronic anxiety that does go along with it. So, and like I said, it's either real or it's perceived stress. Okay, so it's not always something that you can see as an outsider looking in that's causing their stress. Okay, it is something that they are perceiving as stressful to them. So stress is a short term, and it's in response to a recognized threat. So, you have an exam tomorrow, right? That may cause a little bit of stress, right? Or your child is sick, right? That can cause some stress. Um, we look at some of the physical effects of stress and heart rate, it goes up, your respiratory rate goes up, GI issues. Some people have diarrhea when they're stressed, others develop constipation, the racing thoughts, right? All those things going through your head. They could be irritable, they could be anger, they could be unhappy, feeling overwhelmed. And then anxiety. Anxiety can linger, okay? And so anxiety, some of the symptoms are going to be very similar to stress, but stress is usually short-lived, right? If I have stress anxiety, generally speaking, I go take that test, or if I have test anxiety, I go take that test, right? My anxiety or my stress is relieved, right? Anxiety can kind of linger. A little anxiety actually helps to keep us vigilant. It also gives us motivation, helps us to learn a little bit better if we're, a little bit anxious, right? But then as we get into the higher levels of anxiety, that is where it can cause some significant issues. So when we look at how do we work with these clients, right? So I have one, she was very anxious. And so, I went in and I just sat with her and she said, "Thank you so much for coming to sit with me. Everybody is so busy." And I'm like, "It's fine. Like, what's going on?" She goes, "I'm trying to call my dad." And I'm like, "Oh Lord." Um, and I was like, I was like, okay, so, he's not answering his phone. And I'm like, okay. And so I just sat with her and I talked with her and I was like, let me, and I was like, I can go see if I can try to call your dad for you. And she was like, that would be wonderful. And then I was like, okay. And I made sure she was settled and I walked out of the room and I'm like, okay. Now I had to think about how I was going to address this when I went back in, right? What do I do? I'm like, I can't tell you, I can't call your dad, right? Um, but it was interesting enough because we, had the 5 minutes of conversation that I did have with her when I went back in. She had completely forgotten about, wanting me to call her dad. I was like, thank you. Um, but she has dementia, she has Alzheimer's, and so we know that that's common, right? Because they lose their short-term memory as they progress. But it stressed me out. Like I was like, I don't know what I'm gonna do now. But I really wanted to get her to relax a little bit. um but encourage them to talk about their thoughts, their feelings, right? A lot of times when we're anxious or we're stressed, right, just getting it out, right, sometimes helps you to feel better. Um, don't dismiss their feelings. This is one thing that we look at effective communication skills. We don't dismiss them, telling them, you don't have anything to worry about because that's not going to help them to feel better. Providing a quiet environment, reducing excessive stimulation. Um, you know, think about, I don't know how, like, when you're out in there's lots of noises and people moving around, that can increase anxiety, so kind of moving them into a quieter environment, giving them an activity to do. And so, whatever activity that may be available, if there's, just groups of people that are doing things, getting them involved with that, that may help as well. Because it may give them another, that outlet too, to talk about their feelings. We could also do even quiet activities, like music, TV, arts and crafts, right? Things to kind of, redirect their focus. We can teach them coping mechanisms. The elderly, it may be a little bit more difficult because, they are a little more set in their ways. But trying to maybe do some relaxation, some deep breathing exercises, going for a walk sometimes. That is one thing that I will say, like working, a lot of your long-term care residents, even some patients or some of the people that are still living at home, they don't get out very often, right? They don't go outside. And so sometimes just getting them outside, in the sun, right? That can be very relaxing, go watch the birds, that kind of thing. And stress isn't always negative. Like I said, a little bit of anxiety, right? That helps us to stay vigilant. Um, Distress is extreme anxiety, sorrow, pain, and then what we call eustress, that is that positive stress. And again, not all stress is bad. And I say that because what is a good stress that somebody may experience? What's a good stress?
Um,
Wedding,
A wedding. Perfect. Yeah.
childbirth,
yeah, yeah. About to get on a
Back
roller
to
School.
coaster.
school. Say that
School.
again, Joseph.
About to get on a roller coaster.
Getting on a roller coaster. Graduation, right? Passing your NCLEX, right? Those are good stresses, right? Um, your body doesn't always recognize good stress from bad stress, right? So you're still going to have those physiological changes that occur, whether it's good stress or bad stress. It's how we react to that stress. And so that is, but this distress that's the extreme, and that can have negative effects on the body if stress stays for long periods of time. Um, Chapter 12 is your roles and relationships. So look at, roles, the roles we play define us. Okay. So what does that mean? So, you're a spouse, you're a mom, a dad, you're a sister, a brother, an aunt, an uncle, a cousin, right? Whatever, a student. I'm trying to think of other things. Um, Right. And so the roles we play, they define us, right? And we don't always, our roles can change over our lifetime, right? So it just really kind of depends. Um, but juggling multiple roles could lead to internal role conflict, right? So what does that mean, internal role conflict? So this could be, I'm just going to I use moms as an example because,
I juggle a lot of roles.
right, you juggle a lot of roles, right? Maybe you're a mom who wanted to be a stay-at-home mom and do all the homemaking things, but, financially it wasn't feasible, right? So now you have to work. Um, and you're working and then you're like, oh, I'm not there for my kids. Like I wanted to be there for my kids. So it can cause some internal role conflict. And then that was just one example, right? There's others I'm sure that we could come up with. Um, but multiple things going on and you're trying to juggle it all. So what about the older adult? So we talked, some of the changes that occur, but what are some role changes that older adults experience?
What's some of the rule changes?
Yeah.
Role changes, you mean?
Role changes, yes.
Well, I mean, from leadership to follower.
Okay, some leadership to follower. What
Becoming
else?
dependent.
Hmm. Going from a state of being independent to a state of dependency, retirement, right? That's a big one. Like, what do I do now? Right? I'm not working anymore. Now what do I do? Loss of family, loss of friends, loss of independence. Um, what happens if I get sick and something happens, right? Then I lose even more, right? So there's lots of, different things that can occur as we get older. And I love this picture of the Walmart greeter because I always used to say this when I retired, I'm going to be a Walmart greeter. I don't know why, but that's my want to be like when I retire. Why? Because maybe it's just a little bit of socialization, right? Get out of the house a little bit. Um, but yeah, so retirement, altered relationships with adult children. So I will tell you that's probably one of the hardest ones, right? Your kids grow up, they move out, they start having families of their own. And I mean, grandkids are awesome, not going to say that, but it's a different relationship with your adult children, right? Than it is with your children when they were
Mm-hmm.
younger. They don't need you as much, right? And so it is different. Changes in housing, right? So maybe they were in a house, maybe they went into like an apartment, maybe they've had to go into assisted living or other types of, living arrangements. Loss of valued possessions, loss of friends, loss of spouse, loss of health, loss of independence, right? Lots of changes that can occur as we get older, unfortunately. And this is probably one of the truest statements ever is loss becomes more common the older we get. Um, and whether it's physical losses within that person or the external, like the loss of the spouse, the loss of the home, the loss of independence, like I
Also, loved
said,
ones.
loved ones, right? Unfortunately, right, as we get older, so do the people that we associate with, right? So there's lots of losses that can occur. So Kubler-Ross, I don't know if anybody has ever heard of Kubler-Ross, but when we look at grief, okay, so Kubler-Ross was a psychiatrist. She did a lot of near-death studies, and she is the one that recognized the five-stage process that is experienced by dying patients, okay? However, comma, we can put this just in the overall grief process for someone that has lost a loved one. And so these are your five stages. We have denial, anger, bargaining, depression, and acceptance. So when we look at denial, okay, denial is this isn't happening. There must be a mistake, right? Something along something
Not
along
coping.
those lines. I'm sorry, Joseph.
What is that? More not coping with
Yeah,
reality?
I mean you're right. It's a stage that people will go through. But it's, like somebody that, lost a loved one, got a maybe got a cancer, a terminal diagnosis. They're like, no, this is wrong. The test results are wrong, right? We're trying, not that it's not, what's the word I'm looking for? It's going to happen, right? They're still processing it. Anger, right? Now I'm mad, right? Why is this happening to me? I hate myself. I hate everybody around me. Um, and if they lost a loved one, they can be mad at that person for dying, right? Um, and even mad at God or their higher, their higher power that they believe in. Bargaining is the next one. This is where um survivors with when they're dealing with grief, they may try to see if there's something that they could have done differently, right? That hindsight is 2020, right? um but with others, in the dying person, we look at bargaining. This could be like, praying like, please let me live to see, a wedding or graduation or, some other significant
My
life event.
90th birthday or something, right?
Right. And I promise, like, I'll do this, I'll quit smoking, I'll quit drinking, I'll go to church every Sunday, right? It's that bargaining. And then after the bargaining, they go into the depression. And so this is where they feel empty, they feel lonely, they feel isolated. And this can stay for, either short term or it could be a long-term process. But then we get to this acceptance. And acceptance is the last stage. And this is where they start, survivors, they start to reestablish new meaning to their life. But then those people that maybe have had that terminal diagnosis, they've just come to the realization like, okay, this is happening. There's nothing I can do. It doesn't mean that they're happy, right? It just means that they have just, they've come to the realization that they have accepted what is going to happen. It's like accepting your fate, kind of. Um, and then, they may start to become a little bit more involved in their care process. So you can apply it to the person that is, the one that is, dying or has had something happen to them. When you can apply it to the people who are surviving, right? So if you've lost a loved one, then you can apply these stages of grief to either set of people. All right, so place these clients in the appropriate stage of grief. All right. So the first one we have is an 88-year-old man who lost his wife to COPD. Hold on. To COPD, 2 years ago. They had been married for 52 years. Though the loss was devastating, he is regaining his sense of hope and making new friends. So, which stage would that be? Denial, anger, bargaining, depression, or acceptance?
Acceptance.
Acceptance. Good job. All right. Number two is a 75-year-old client a 75-year-old client was just told that his son was killed in a car accident. He says to the nurse, check the name again. You must be wrong.
Denial.
Denial.
Very good. Denial. Number three, a 65-year-old manager was laid off at the company where she worked for 40 years. 6 months have passed. She tries to pretend that everything is normal, but she is deeply depressed.
Depression.
Okay. A 78-year-old woman was diagnosed with stage 4 lung cancer. She makes a large donation to the American Cancer Society, hoping that it will help her heal.
Bargaining.
Good job. And then we have an 82-year-old woman has found out her husband didn't survive his surgery. How could he leave me like this? She asked the nurse.
Angry.
Angry. And they say it at the end.
Good job. Yeah. Well, I didn't say it. I left that out purposely, but it was already on the slide, so I couldn't I just like if I skipped the word.
Oh
Good
no,
job.
I'm not saying your part, but look at they say asked the nurse angrily.
Yeah.
And
I
the other
know.
one had
Well, the
depressed
other
at
one
the
said
end of it.
depressed.
But very good. You guys did great. Awesome. All right. So grief. Um, and you can go through those stages. Grief is a very strong emotion, and there's lots of things that can cause us grief. It becomes complicated when a person has an exaggerated or prolonged period of grief, greater than 2 years. And we have seen this too, where they really just never get over the loss. um, so when we look at how we deal with somebody who is grieving, and this is hard because, a lot of times when we are working with our clients, we tend to focus a lot more on like the physiological things, right? We don't always pay a lot of attention to those psychosocial aspects. But with the elderly people, we're kind of forced to address these issues and they need to be addressed. Allow them for verbalization, let them talk about it, um, use, your therapeutic communication skills, let them reminisce, let them talk, let them discuss how they're feeling, use available, support systems. There's a support group for everything. I feel like there's a support group for everything. Okay. All you have to do is get on Google and Google. Um, and so it could be a support group because they don't have any family, or what is their support system? Is it their kids? Is it their friends? Who do they go to when they really need somebody? And so, encouraging that, encouraging them to participate in their ADLs. Biggest thing that we want to do is prevent that social isolation, right? Social isolation is not good for anybody, especially long term, right? If you don't feel good and you're going through something and you want a couple days to yourself, like, right, we get that, right? That's perfectly understandable. But we don't want it to last for long periods of time. And we have to be really careful with that. And especially, they can easily become socially isolated, especially if they don't have effective ways of dealing with grief, or stress. Which is going to bring us right into how do we cope with grief and stress. But I will give you a break. So be back at 4:10. All right. So, chapter 13, coping and stress. And so we know stress is a normal part of life, right? No one lives without stress. And again, stress can occur when it's a real or a perceived threat, or even experience a life altering change. Older adults, right, suffer from numerous chronic or acute conditions under greater stress. Again, we talked about loss of family, loss of friends, right, loss of spouse, change in residence, change in financial status, right, can cause stress. Um, and so, we all face a nice steady stream of of life and stress that can occur there's throughout our lives. um and so there is we call the general adaptation, what is it, general adaptation theory. um what happens when we become stressed? Okay. So I'm just going to use this. You're driving down the road and a deer jumps out in front of your car, okay? And you have to slam on the brakes, right? And we get that initial fight or flight response, right? And I'm sure everybody has been in that type of situation, whether it's a deer or a dog or a child or, somebody pulls out in front of you. And so we have that initial fight or flight response, right? And so the heart rate goes up, the blood pressure goes up, your respiratory rate goes up, your pupils dilate, you might start trembling, um, become pale or flushed skin. And of course, there's other, responses that occur with that initial fight or flight, stage. Um, and like I said, everybody's probably been there at least once in their lives. Um, so which of the following would be considered signs of stress? So we have the increased blood pressure, we have the decreased urine production, increased frequency, muscle pain and headaches, deep, refreshing sleep, calm, productive mood, high blood glucose levels.
Increased blood pressure.
Yes.
Muscle pain and headache.
Okay.
I feel like the decreased urine production could be one of them.
Very good. Absolutely. All right. So what about the high glucose levels? Why? So this is, so I don't know. So again, with your fight or flight, so the blood pressure, pulse, respirations go up, your pupils dilate, um, muscle pain and headaches. I carry my stress in my shoulders. I don't know about anybody else. I carry it right here in my shoulders. And so I'll tense up, and then what do I get? I get a headache, right? And then it's like, what do I do now? Why do you think high glucose levels is a sign of stress?
Cortisol raises glucose.
Okay, cortisol raises glucose. So fight or flight. Okay. I either gonna run or I'm gonna fight, right? And with the increased metabolic activities that are going on, higher blood pressure, pulse, respiratory rate, what do I need? I need glucose. I need fuel, right? So I'm either gonna stay and fight or I'm gonna run, right? So I need fuel. And yes, I'm sorry, but I don't remember who said it, but the decreased urine production and increased frequency, right? The GI tract slows down during that fight or flight response. Amani, did you have a question?
No, I was saying I didn't understand the glucose part, but you explained it.
Okay, cool. Um, Depression and alcohol abuse. And so when we look at depression and alcohol abuse, um, I don't know, some of you might know some people that abuse alcohol, but their slow mood, they sleep a lot, increased number of falls, Urinary incontinence, memory loss, confusion, are all signs of depression and alcohol abuse. And so, they are depressed, they feel depressed, they, want to alleviate, right? So turn to alcohol. Um, and then the effects of the alcohol, right, can cause additional symptoms. But one thing, what do we know about alcohol? What does alcohol do to our central nervous system? Anybody know?
It depresses it.
Absolutely. So alcohol is a central nervous system depressant. So if I'm already depressed, what's alcohol going to do?
Make it worse.
Make
Make
you
it
more
worse.
depressed.
Very good. And again, you can have the older adult that is going to use alcohol as a coping mechanism. Signs of substance abuse should be considered, even if it seems unlikely. Okay, they won't do that. um, and a lot of times too, it can mimic the changes of aging. And so it often can become overlooked. I mean, generally speaking, we don't think about the older person who's drinking a lot or even, going out and using drugs. Um, I actually worked in a facility right before COVID where we had caught a resident who was smoking crack in one of the bathrooms and had decided to enlist other residents. And so there was a whole group that decided that they wanted to smoke crack in the bathrooms in the long-term care facility. So it can happen. Um, so, the signs of substance abuse, they could have bone density changes. Think of osteoporosis. We know that's very, common in our postmenopausal women. Urinary incontinence, right? Although incontinence is not a normal part of aging, right? It is common in a lot of our elderly. Altered sleep patterns, right? Also common. GI problems, loss of balance, frequent falls and injuries, right? So it can, you know, um, mimic some of the changes that occur with aging. So there are healthy coping mechanisms out there, right? So what are some healthy coping mechanisms? What are good healthy coping mechanisms?
Working
Exercise.
out.
Meditation.
Meditation, exercise.
Exercise.
Mhm. What else?
Um, like having different
Vacation.
hobbies, like doing like art projects and stuff, or even like hiking.
Okay, hobbies. Absolutely. Somebody said something else.
Counseling or social support.
Social support, right?
Vacation.
Like, say that one more time, Amani. I'm sorry.
Vacation.
Vacation. I want a vacation. Let's all go on vacation. Um, right. So music, um, sitting outside, like enjoying the sun, going to the beach. That is my best coping mechanism. I can just go sit on the beach and listen to the waves and smell the salt water. What are some unhealthy coping mechanisms?
Drinking, drugs.
Drinking, drugs, what else?
Binge eating.
Binge eating, that's a good one. Yep. I mean, it's not a good coping mechanism. That was a good answer. Let me rephrase how
Taking
I said that.
Having
taking
relations with more than, because your older population, um, they start to have relationships, well, sexual relationships with a lot of people.
yeah.
Yes. There is a high rate of STDs in our older population.
Yes, it is a high
Yeah,
rate.
there is. And then people don't always think about that, but yes, there is. Um,
Isolation.
Isolation, smoking, drugs, overworking or overextending yourself, right? Trying to do too much. Excessive caffeine use, that's probably mine. That's my ineffective
That's not
coping
unhealthy.
mechanism.
Caffeine is good.
I agree. But yeah, generally speaking, those are unhealthy. But then even going to get a massage. I'm not a fan of massages, just saying, but for a lot of people, they're very effective. Meditation, um, those are all can prayer, reflection, that kind of thing can be very helpful in some people. What is that other one? What is it? Is it, I don't know, I'm probably saying it wrong. Is it Reiki? Some,
Reiki healing.
thank you. I'm like,
I've done
I
that
know I'm,
before. I love it.
yeah. So that, right, that can be helpful to some. Sometimes just sitting by yourself and reading a book, right, can be a coping mechanism. Counting to 10, taking a few deep breaths, right? Those can be effective. And so when we look at coping mechanisms and your mental health, so common, these are common coping mechanisms. And so bunch of words. So repression is removing anxiety producing thoughts or experiences from your conscious mind. All right. So trying to just, repress them so that they're not there. Denial, we've talked about denial, right? Refusing to acknowledge some painful aspect of reality. So, the loss of a loved one, a bad diagnosis, something along those lines. Rationalization is creating an acceptable reason for unacceptable thoughts or actions, right? So, oh, I did this because of this. Displacement is transferring emotions about one person or situation to another, right? So, you're mad at your spouse, but you're, yelling at your kids, or you're yelling at your friends, your caregivers, whatever. Projection is attributing your own feelings to another. Sublimation is channeling negative energy into acceptable or socially acceptable behaviors. And then substitution. Sometimes this is one of my defense mechanisms, is staying busy so you don't have to think about stressful things. Doesn't mean they go away, right? It's just like you're ignoring them, and you're just, substituting one behavior for another, which isn't always the best, right? Because you still have to face the stressful situation. You can't just ignore it. Which then brings us to chapter 16. So I'm going to go back to what Mahisha was saying. Older people are still sexually active. Okay. And so just because I get older doesn't mean that the need for sexual activity disappears, right? Of course, the frequency, the type of activity may change, but they still have that need for intimacy, right? Um, and yes, the sexually transmitted diseases are increasing in the population of those 65 years and older, including HIV and AIDS. So it's, yes. And older adults also are more susceptible to contracting HIV and AIDS than younger adults. Why do you think that happens? Why are they more susceptible?
Maybe just because they already have like a lowered immune system, and with them being in their older years, they probably don't worry about protection as much as what like a younger adult would.
Absolutely. So yes, their immune systems are declining. And yes, why use protection, right? Why use protection? So another thing too is we found in the older adult population too, right? We know that women generally live longer than men, right? So the population of the older adults, more women than men. And so men have more availability. Okay. So they can go from one to the next. And right, they don't, think about protection, right? Because majority are postmenopausal, they can't get pregnant, right? So they don't worry about it. And so, yes, we have that high rate of STIs, including HIV and AIDS. With women, normal age-related changes, Of course, we have the decrease in progesterone and estrogen that occur, right? Especially that postmenopause. They may have some discomfort during intercourse, which is your dyspareunia. And that's just related to the changes that occur postmenopausal. So one of the big ones is vaginal dryness, right? And so that can lead to uncomfortable sex. And so we, teach them to use, the water soluble lubricants, okay, like KY jelly versus Vaseline, okay, because they are generally safer, they clean up a lot easier, and they also have fewer side effects than even hormone replacement therapy. And that's a controversial state, that's a controversial, um, treatment. Because of the side effects of the hormone replacement therapy, um, other alterations within, age-related changes also can, be caused by illness, stress, medications, right? Um, so variety of things that occur. Medications like anticholinergics, your antidepressants, chemotherapy can affect their libido, right? So we have to worry about that. So we have a 72-year-old woman who reports she is sexually active. It is most important for the nurse to follow up by asking which question. What are we going to ask a 72-year-old woman who says she is sexually active?
Ask her when was the last time she had sex.
Okay.
If she remembers the person she had sex with.
How many
Wait,
partners?
Did she
they're getting
use
checked for
protection?
STDs?
Okay. Okay. All of the above. Awesome. Very good. So yes, so here we go, right? Um, Tell me more about your sexual partners.
Oh God.
Um, Actually, I would probably ask most of these, but yes, your sexual partners. Like I said, women outnumber the men. So men can, kind of spread their
Yeah.
love, I guess would be the appropriate way to say that. Okay. And
Yeah.
if we,
Would you also ask them, like, if they feel safe when all of those things happen? Do they ever feel forced or anything like that? Like what,
that
you know?
that is really good, Ashley. Yes, absolutely. Right. Because we asked that of younger women. Why would we not ask that of older women? Very good. That was awesome. Um, Men. Age-related changes. So older men can experience a delayed reaction to, sexual stimuli. They may take longer to achieve an erection. It may not be as firm. The orgasm takes longer. It has a shorter duration as well. And it may not even occur with every, sex, or with every episode. Erectile dysfunction is also a common problem. So erectile dysfunction, and that can occur in even a younger person, but ED is the inability, geez, to achieve or maintain an erection during intercourse in more than 50% of attempts. Other things that affect diabetes, depression, cardiovascular disease also can, lead to erectile dysfunction in large prostates in our men, whether it's benign or not in or cancerous, right? Can also affect uh, so variety of things that can lead that. So Mr. Washington is visiting his provider for his annual checkup. His vitals are 138/78, respiration 16, 96% on on room air, I'm assuming, 97 degrees Fahrenheit. He has a history of hypertension, has never smoked, has and drinks a glass of whiskey shortly before bed. After grieving the loss of his wife 3 years ago, Reggie is ready to start dating again. He attends his local senior mingle group and has met a woman he is interested in having an intimate relationship with. Mr. Washington has noticed that he does not become as aroused as before, despite having feelings for this woman. Um, he asks why this occurs. So, what information here would be significant?
The
Well,
hypertension and even just like the little bit of whiskey, because alcohol can affect your ability to get and maintain an erection.
Absolutely. Yep. It has a huge impact on sexual function in the older adult. Yep. Hypertension, like I said, right? Hypertension is one of the reasons why, or it can lead, or cardiovascular disease can lead to problems with arousal as well. So hypertension, the whiskey, grieving too. Missed that, right?
depression.
So yeah, very good. And so we're going to include education about normal age-related changes as well as those sexually transmitted infections, right?
Yes.
After reviewing a list of Mr. Washington's meds, which medications should be questioned by the nurse? Here's a good one. So we have furosemide, 20 milligrams every morning. We have verapamil, 180 milligrams every 12 hours. We have vitamin D3 every Monday and Thursday, Tylenol, PRN, ginkgo biloba, 60 daily.
The
So what,
ginkgo.
okay. And then what do you guys know? Does everybody recognize those drugs? Yes, okay. All right. So ginkgo, anything else?
I've it's not like fully registering to me right now exactly what it is, but the furosemide is definitely familiar. I feel like I just did this with one with the geriatrics clinical with one of my patients.
Okay.
So,
This
but I don't remember exactly what it's for.
Okay.
the second one, I know I'm not gonna say it right, so I'm not gonna try, but the second one is a calcium channel blocker and it can cause ED.
Mm-hmm. So furosemide's Lasix. It's a diuretic. It's gonna make him pee.
Okay.
Verapamil, yes, you're absolutely correct. It's a calcium channel blocker. He is probably on that for his hypertension, right? All right. So antihypertensives. So furosemide, very good. Diuretics and calcium channel blockers can cause ED. Ginkgo can decrease blood pressure and improve ED, but they need to consult with a provider. So consider changing doses if blood pressure is controlled. You can also ask about Viagra. What's Viagra?
ED2.
A PDE5 inhibitor.
Yes, and it's used for
You know what it's used for.
it is used for
Dilation.
you are funny. It is used for right erectile dysfunction, right?
Isn't it used, let's just say like in the more professional way, isn't it used for like blood flow?
Yes.
So
Yes. Yes.
so yes. So just a little bit of history because I am a big farm
That was a
geek.
strong yes, bro.
Yeah.
Yes.
I'm a huge pharma geek. I love pharmacology. So Viagra, when it was first being made, it was actually being made to be a blood pressure medication. Okay. And during the clinical trials, they realized that it had the effect of causing erection. And so, yes, it increases blood flow to the penis to allow for the erection to occur. And so, rather than marketing as a blood pressure medication, they now they change their view and they market it as an erectile dysfunction med. I will tell you what's even more interesting about this. Women can also take Viagra. I know
Yeah,
what.
I just asked that question. I have two witnesses right here. I was like, what would happen if you take Viagra as a woman? Like, where does the blood flow go? Oh my God, you just read my mind.
So where do you think the blood flow goes? I'm gonna need you to remember anatomy and physiology.
To the heart.
No. If it were going to use it for erectile dysfunction, where is it?
Clitoris?
Thank you. Yes, because the
Right, we
clitoris
right.
also becomes erect. Okay, so it does increase blood flow to that area as well. But women, yes, women will have the same effects. It does increase their libido, okay? But you also will have women that take it for blood pressure. Yes, because it, like I said, it was originally marketed as an antihypertensive, or was originally being developed as an antihypertensive. So you may see women that are taking it for their blood pressure. So yeah, so it's kind of got a twofold going on in there.
People take it before the gym too.
I did not know that. Thank you, Aiden. Why?
It increases blood flow all throughout the body, not just
Well, so
and
like when they're working out, I guess, to
yeah,
get more blood
yeah.
flow to them.
There's
Interesting.
actually
I didn't know
studies
that.
that show it's almost as good as exogenous testosterone.
Interesting. I did not know that. Thank you, Hayden. Okay. I mean, it makes sense now that you said it the way you said it. Interesting. I did not know that.
Go
All
Viagra.
right. I'm sorry.
I just can't imagine it because I'm like, are you just like, because I know what it's for. So y'all in there working out, and is it just like up the whole time while y'all working out?
I think that
Nah.
in order for it to, and I can, that thought did process, okay. But in order for it to function as a erectile dysfunction medication, there still has to be a stimulus. Like they still have to have the stimuli to cause the erection. Does that make sense? So it's not just like, boom, I'm there. Like they
Hmm.
still have to
That's not
have
how it works.
some
Yeah.
stimulation. Um, so how does illness impact sexual health, right? And so we already talked about this. Cardiac problems, diabetes, COPD, weakness, paralysis as a result of as a result of a stroke, right? Obviously can have some effects on the reproductive system. Chronic depression, incontinence, right? These are all concerns when we look at, sexual health in our older population. So sexuality of our older
Ms.
adult.
Martinez,
Yes.
I just want to let you know that we're still on the topic on how you read my mind.
Oh.
Because as I said that out loud, then you said, women could take Viagra too.
Yes. I'm like, I wish I had that ability to read your mind, but I was like, I'm just gonna say it because I didn't know if anybody would ask. So, um, but address issues in private. Obviously, when we're talking about sexuality, we don't want to be in the middle of the hallway, right, in a group of people. Ask those open-ended questions, right? Open-ended questions gonna give us the most information. Um, they also may, and we know society is a lot more understanding about the LGBTQ community, right? However, you got to look at this population. This population, especially our baby boomers, were a lot more private, okay, just because society was different, right, when they were younger. So they may be uncomfortable disclosing their sexual orientation just for fear of discrimination. With non-cognitively impaired consenting adults, all right, if even in a long-term care facility, if they wish to engage in sexual practices, okay, with consenting, they have to be consenting. Okay, we do need to allow that, give them the privacy. Where we have the concern is in those cognitively impaired adults, right, who cannot consent. That is where we have to really be careful to protect those clients, because they can't consent. Okay, so we need to protect them from any undesired physical contact. All right.
Sorry about that. I actually have something to add on to that with the cognitively impaired. I worked in a facility once where there was two different patients that were actually diagnosed with dementia, and those two were constantly like getting caught together and everything. So what they did with that, because it was like hard for them to keep them separated, they spoke to their families and got consent from their families because it was like such a hassle to try and keep them apart from each other. Like they even went to the extent of trying to move them, like move one of them to a different floor, but the families threw a fit about that. So then they went the route of getting consent from the families for them to do whatever.
Correct. We had a situation where we had a couple, it was a husband and a wife who were both in our facility. The wife had dementia, the husband did not. And he's still engaged with her. So, but we had to do that as well because even though they were married, she was not cognitively able to consent. Okay. So we did have to talk to the family about that as well. Because you don't know family dynamics a lot of times. You don't know what their past history was, right? With that. So we had to do that as well. We had to go to the family and be like, this is what's going on. Like mom and my dad still wants to, but mom can't say yes. So how,
Now, I have a question.
Mhm.
How does that work? Because I know there's like severe dementia that can cause like Alzheimer's and stuff like that. But what if it's just like short term and something that like you just
Like a
take?
delirium.
Yeah, like it's like short term. Like when you have short term memory, like you don't know why you walked into the room, but you're still aware. You have your five senses. You're just like more forgetful with age, you know?
So the healthcare provider, the psychologist, psychiatrist at that point would be the one to determine their mental capacity as far as consent would go. Because like I said, it's about protection, right? Older adults are considered a vulnerable population, even if they don't have a disease process. Okay, just being an older adult is a vulnerable population for a variety of reasons, abuse and neglect and, all of it, all of the above. And so when we look at something like that potentially occurring, right, we would always go to the provider to make that determination. All right. Excuse me. So we have a 90-year-old client in a dementia care unit starts undressing during a meal in the dining room. What's the nurse's best response?
Redirect the client to provide privacy.
B.
Okay. So redirect and provide privacy. Absolutely. Right. We have a dementia patient, right? Doesn't understand the social environment. So we are going to redirect them and provide for privacy. Absolutely. All right. You guys did awesome. So I know we covered a lot of information today. What questions do you have for me?
This is I know this was our lesson, but mostly everything we talked about is going to be on the test. And you got the exam review 2 up, right?
I do.
All
Yes,
right.
sir. Yep. And then as the exam reviews are being completed, I am putting the recording links in the announcements so that you can access them.
Thank you.
Absolutely. Trying to remember when mine is. I need my calendar.
Can you put another Kahoot?
A
Yeah, they
Kahoot?
will
Yeah.
yeah,
Yeah.
they will. They
That
will.
helped me
Yep.
out a lot.
So 134, mine is on Sunday at 8 p.m. Eastern. Okay, so if you can make it. But like I said, all of the recordings as the instructors are doing them, all the recordings will be posted in your announcements. So
Hold on. You doing something Sunday night
Sunday night.
on the Super Bowl?
Look now. I didn't make the schedule for the exams,
Come
okay?
on.
My team didn't make it to the Super Bowl, so don't bother.
Mine's didn't either.
Who are you? Who's yours?
Giants.